Fluorescence guidance during robotic resection of bladder wall endometriosis. Technique and video with the application of indocyanine green to visualize bladder and ureters. A 41-year-old patient was referred with symptoms of dysmenorrhea and polycythemia. On CT, a 2 cm endometriosis nodule was seen at the posterior bladder wall. She was referred for robotic surgery. On the left side, you see on the CT scan a 2 cm nodule in the posterior bladder wall, and on the right side, details of the nodule. The bladder was filled with 200 cc of physiologic water with indocyanine green and clamped. For the dissection, we start with opening up the bladder peritoneum. First here, dissecting with a unipolar scissor the peritoneum at the junction between the round ligament and the uterus. Here you see the round ligament, the filled bladder with ICG, coagulation of some superficial vessels, lifting of the round ligament, and here opening up the peritoneum and the retroperitoneal space. The approach for a central nodule is going first laterally. Lifting of the peritoneum with unipolar scissor, dissecting further, deeper. Then we go on the right side. Releasing the nodule superficially. Slowly you will see some transparency of the bladder wall because it becomes thinner, because we are dissecting in the muscular layer of the bladder. Coagulation of small vessel here. Then you see here bilaterally transparency of the posterior bladder wall with ICG and still the central nodule of the endometriosis. With unipolar scissor, releasing superficially this nodule from the posterior bladder wall. Now full transparency with ICG. Here we grasp the right round ligament, cutting it with unipolar scissor in order to open up the retroperitoneal space and to have more access to the right side of the cervix and the dissection of the nodule. Releasing the bladder there, and then further dissecting the nodule more in the depth and releasing it, detaching it from the bladder. Slowly you will see the anterior part here of the cervix, releasing there totally the bladder from the anterior part of the cervix. Here we seal and cut with the vessel sealer extend the fibers and endometriotic nodule there, the fibers between this nodule and the right bladder pillar, the distal cervix there, full transparency of the bladder. And because we clamped the bladder, you can see here the distal ureter filled with ICG, so retrograde filling. Here you see the left uterine artery, distal part of the cervix, and sealing, cutting here the paracervical tissue. On the left side, you also see the ureter by retrograde filling with ICG. This is the endometriotic nodule, and after removal of the uterus and closure of the vagina, we start with suturing the posterior bladder wall in a longitudinal way. We do it in 2 layers, first the submucosa and the muscular layer, and then as second layer, the muscular layer and the serosa. We use here a monocryl 3-0 stitch. We use approximately 3 to 4 stitches for the first layer. Then the second layer, which is the muscular layer and the serosa of the bladder. We also use for the second layer 3 to 4 stitches. After suturing the whole bladder wall, we check whether there is any leakage or still transparency. Here you see, can beautifully see actually the ureters. Now we fill the bladder with 200 cc of physiologic water with ICG, no transparency and no leakage. The right ureter, the left ureter, and no transparency. As conclusion, ICG with near-infrared imaging provides clear anatomical planes of the bladder and ureters during complex urinary tract endometriosis surgery.